Hello, everybody. My name is Guillermo Garcia-Manero from MD Anderson Cancer Center in Houston. I'm very happy to be here today at the ASH meeting in San Diego, hosting this roundtable for blood cancers today with my colleagues from New Jersey, LA, and Miami. We're going to be discussing topics related to myelodysplastic syndrome.
Hi, I'm Jamie Koprivnikar. I'm from the John Theurer Cancer Center at Hackensack University Medical Center. It's a pleasure to be here today.
I'm George Yaghmour. I'm the Associate Director of the Transplant Program at USC Los Angeles. Genuinely honored to join you today for this discussion.
I'm Sangeetha Venugopal from the Sylvester Cancer Center, University of Miami.
Let's start with the first topic that we want to address today, that is the COMMANDS trial. So the COMMANDS trial was first presented at ASCO last year, then EHA published in a major paper in The Lancet, but it was an interim analysis. So actually the full analysis of COMMANDS is going to be presented tomorrow at this ASH meeting. So Sangeetha, what is your opinion of this kind of update or final analysis of the study?
The one thing I was looking for was the ring sideroblast status. So in ring sideroblast, patients with ring sideroblast status positive and in the Luspatercept did have a robust response in who were transfusion dependent. But in those with ring sideroblast negative status, both Luspatercept and recombinant erythropoietin had comparable responses. So I'm looking forward to dig into the data. So why was this happening?
Well, COMMAND study was practice changing for us when we saw the data that showed us significant improvement in transfusion dependency in low-risk MDS. And based on the COMMAND study, we all got excited. Okay, we have a new now standard of care for a patient even naive to erythropoietin stimulant agents. The question is, in the ring sideroblast negative or without spliceosome mutation situation, despite that it's non-inferior, is it going to be better in the survival? What is the additional mutation would add to the decision of the treatment or the combination therapy? Also, it's more to investigate it and to discuss in deep.
That's wonderful, Jamie.
You know, I think it's interesting, even though we did see approximately equivalent response rates in patients who had RS-negative disease, certainly we saw a longer duration of response, and I think the dosing interval was a bit more convenient at the every 3-week dosing for Luspatercept. So I think based on the data we have now, I agree with you, the forthcoming data will be really interesting. I still generally will choose Luspatercept even for my RS-negative patients.
So I think what we are going to see tomorrow is going to show actually that this data of the RS positive versus RS negative in terms of response neutralizes a little bit. So the update shows that they're kind of very similar, if not identical. And something that Jamie mentioned that I think is very critical is what I refer to as the quality of the response, that is the duration of response. So from the beginning, what really attracted me to those results was not just the higher response rate, but actually the fact that those durations are significantly longer. And something that we are starting to see in this updated data is actually the duration of response in RS negative patients appears to be longer than actually the RS positive. So I don't know if there is a statistical power. For sure, I agree, we need a lot more follow-up in understanding this. But the question actually that I see in the community, I'll keep going like this, is this issue that Jamie was addressing already of, do you treat RS negative patients at the University of Miami with an ESA, or you think that the data with Luspatercept is good enough to just use that in front line?
I would agree with Jamie in using Luspatercept even in RS negative patients. And I completely agree with you about the quality of response. The duration of response matters more than the RS negative or the RS positive status.
Well, I support and I agree that seeing the curve of the duration of the response, and we know they both has a similar transfusion dependency, I would be still more encouraged to consider Luspatercept. And especially this ASH, we have some data focusing on RS negative and additional mutation of the COMMAND study, which is interesting. That's high risk mutation, still showing us Luspatercept might be a winner.
Can you expand a little bit on this? So how important are these molecular kind of characterization of the disease when we
So it's still, yeah, I mean, it's a good question. It's still so controversial is having more mutation panel and including the MIPSS scoring system right now and having those bad player, not the spliceosome mutation. And in the arm of the RS negative, there is some follow-up data this ASH. I noticed the abstract talking about in RS negative, if you have the higher risk Luspatercept population did better than the erythropoietin stimulant agent. I don't know if you agree or what do you think about it?
Yeah, I think it's interesting. There were a number of interesting sort of commands adjacent abstracts. And to the point of sort of the durability of response, one of them did show that in the RS negative patient population, they kind of had a slow, steady deepening of response with really a maximal time to response of 48 weeks, which is a long time. Sometimes my patients get impatient, so I'm really going to have to convince them that they need to take their time and wait for it. There's also some interesting, sort of real-world data focused around Luspatercept. And what I found interesting is that more than half of patients, based on some of, this real-world information, were actually started on treatment when they were not actually requiring transfusions.